My name's Helen Tucker. I was formerly president of the Community Hospitals Association, and delighted to be hosting this special interest group that we run through the Q community, part of the Health Foundation. We do a series of discussion groups throughout the year, once a month, and particularly interested in this one. Mark, as you may well have caught him at the conference, Mark from Seachange ran workshops at the conference and attracted an awful lot of attention, and we've had a lot of comments on it afterwards. So we thought it would be brilliant to follow that up with a discussion group so that we all get a chance to ask questions and dig a bit deeper into what Seachange is all about. So thank you for agreeing to do this, Mark. That's wonderful. So just a couple of housekeeping. If you've, we're going to carry on through the whole presentation. At the end, we'll take questions. If questions occur to you, please put them in the chat, and Eleanor will pick them up as we go along. We are recording this session, so I hope you're comfortable with that. At the end of the session, we will ask for feedback, so you get a chance to do that. And at the end of this session, Eleanor will tell us about more discussion groups in the future. So the fun continues. But I think there's a good group of us, and I know it's only 2 minutes past 7, but I think we may get more people joining us. But welcome to everybody, and I think without further ado, hand over to Mark and ask him to take us through what's happening with Seachange. Thank you, Mark.
No, thank you, Helen. Thanks for inviting me. Presentations aren't always my thing, so this is going to be quite a casual thing, really, and hopefully not death by PowerPoint. But let me know if it is, and I'll try and move on. I'm not a clinician. In fact, my background was 20 years in the police. The last 10 years, lastly working in custody units as custody sergeant, custody inspector, and that environment changed dramatically over that period. Gone from merely arresting people and trying to charge people to actually looking after them, because 9 times out of 10 people come into custody with mental health issues, with alcohol, drug issues. So we work with a range of people, from specific custody nurses who are present on scene, to custody doctors taking samples, to mental health team and social workers who are all based in the station. And yet when I first started, it was just me and my friend booking people in, and they wondered why people died. So it's completely changed, and I think that's one of the reasons why I ended up working where I am at the moment, which is running a little charity called Seachange in East Budleight. So I will share my screen and to you about Seachange. Hopefully you can all see the screen.
Yep.
So, what we're going to talk about is a little bit about our history of Seachange, where it's come from, where it's been, and hopefully a bit about where we're going to, with a little bit of future. A little bit about what is a hub. There are lots of definitions and understandings of what a hub is, but in actual fact, it's probably lots of different things. We'll talk about our mission and values, talk about exactly what we're trying to do, a bit about our impact, and then why isn't everybody else doing it. So that's us, that's our building, our beautiful building. Not quite, in fact, it used to be beautiful down there at the bottom. That back in 1887, when the local Lord of the Manor, Lord Roll, built the hospital, it was on subscription basis. So if you paid your subs, you could use the hospital. And that was about the same sort of time when the railway line came through Budleight. And at the top, you can just see the cottage pitch roofs at the front of the building, and the gorgeous 1970s extension to the right and to the left, and the sunroom at the top. So it's about 1,400 square meters, the building. Most of it is unusable space, being an old hospital, i.e. there's lots of wide corridors, there's lots of toilets that we don't really need. But it is the building we've got, so it's what we have to work with, and because of that we do quite like her in a funny sort of way. Um, NHS came into being 1948, and we gave the building, or Lord Roll gave the building to the NHS. Felt like it was the right thing to do at the time, I'm sure. Um, Over the years, it's been owned by various bits of the NHS, various trusts. Um, but it was given to NHS Property Services when they came into being, and they still own the building to this day. It was a stroke unit hospital latterly before it closed in 2014. It had 5 years of being a 15-bed stroke hospital, with a few outpatient services attached on the end, before its demise in 2014. Um, it had a league of friends, as most hospitals do, have good, well-meaning people who like to provide the nice bits for the hospital and the staff and the patients. And they obviously led a campaign, as most local communities do, to save their hospital, which in one respect failed, um, because the hospital still closed, and it closed for nearly 4 years. And during that period, it took a dynamic group from that League of Friends to find a new model and find a new way of keeping the hospital alive. And I think if they were being, well, I know if they were being honest, it was more about keeping the building alive than understanding what they wanted to actually do. Um, they knew that they were going to lose an argument about trying to keep inpatient beds. Um, Sorry, my dog's just arrived. They knew they were going to lose an argument about inpatient beds, so they had to move on and find something else. And they linked up with a local charity called Westbank, who had what's called a healthy living centre, which back in the 80s, 90s, was a form of hub. And they brought them on board. And with the permission of the CCG, NHS England at the time, and the goodwill of what was the PCN, well, called the PCN then, um, the local practices, all came together, and in 2018 it opened. There's a nice little picture there of the big opening ceremony. Now, obviously, I've just explained that in 30 seconds, but that took 4 years to come to fruition, and a lot of pain from a lot of people, and a lot of convincing. But the League of Friends of Budleigh had some, retired, powerful people, ex-bankers, ex-senior accountants at national law firms, who were really motivated to push it forward. And that's the key reason why it got pushed forward, is because of their motivation and determination. It would not have happened otherwise, because they just wouldn't give up. In fact, it was the head of the CCG that signed it off on her last day at work, um, that managed to get it over the line. So in 2018, it opened. Um, we were given some funding by the CCG, because they used to spend about £1 million a year keeping the hospital closed. So they were effectively paying the rent to the NHS Property Services, the maintenance charges, which added up to about £1 million a year. So the League of Friends said, well, why don't you just give us half of that? And then, we're saving you £500,000 a year, and we're keeping the hospital open. Um, the League of Friends put in another £500,000 to refurbish the building. And with 3 years funding from the CCG, we managed to move forward. But it was quite clear that that funding wasn't going to continue. So we had to come up with a new way of trying to fund ourselves, and I'll quite happy talk in more depth later on a bit about that. But we needed to form another independent charity in order to seek funds from other organisations, from grant-making trusts, from individuals, sponsorship from companies, as well as receiving general donations. And so in 2021, when we had plenty of time to think about things, we came up with Seachange. And Seachange is a play on words, because we're by the sea, and it's about coming to us and seeing change in yourselves, or seeing change in your friends and your family. So we are in a part of East Devon, PCN network of just under 50,000 people, which is called the primary network. So that's Woodbury, Exmouth and Budleigh. And that bit of East Devon is relatively wealthy on a national scale of things. But it is has pockets of deprivation. It's a coastal community, which are generally poorer. It's a rural community. It's a farming community, and it's a big retirement community. So, as a percentage of population, we have more people over 65 in our PCN than any other PCN in the country, and Budleigh has, as a percentage, more people over 75 than any other place in the country because people love to come and retire and live down here. So, we're set up with these various missions, and it's about things that are quite well established in society. And by that, I mean, these are things that Chris Whitty has talked about on many occasions. The Darcy report, as I know many of you know about as well, have talked about how social isolation and loneliness really, is at the heart of our problem with the NHS, I would suggest, in that if we could get to the bottom of that, we can tick a lot of boxes and solve, a hell of a lot. It brings in so many other comorbidities. It obviously makes you, more unhealthy, more likely to make bad health choices, more likely to drink, more likely to smoke, do less exercise. That impacts on you falling over. You're going to fall over more. You're going to use your GP more. You're going to use the NHS more. You're going to get admitted more often. You're going to be in hospital longer. And will struggle to take you out of hospital, and all that adds to cost. So we also want to boost people's health and happiness. If you are happy, generally speaking, you're going to be healthy because you're going to be treating your body well. We want to enhance the well-being of the community as a whole through education services and providing general support. We want to provide warm and welcome spaces for everybody to use. That's a kind of terminology that's come in since COVID, and since the cost of living crisis, where we want to be open for those people who can't afford perhaps to go anywhere else and would otherwise just be sat at home on their own. And we want to enable all members of the community to live longer, better lives. And that might be a phrase that you know quite well, but essentially most of us on this call, I would suggest, are reasonably healthy and probably reasonably wealthy, which means we'll live a nice long life to 82 and drop down dead. Of a short illness and probably not use much of the NHS up until that point. Whereas some parts of our community are having health issues from 50, 55 onwards because they've made bad life health choices. They will draw on the NHS for the next 20 years, and at maybe 70, 75, they'll then drop down, having spent quite a bit of money in the meantime, when there's no reason why they need to be doing that, because a lot of those illnesses are preventable. So it's about not smoking. It's about doing exercise. It's about not having diabetes because your diet isn't good. All the usual common sense things that, as Chris Whitty would say, we used to do in a kind of Victorian age of looking after one another, that we seem to have lost. So what do we actually do? And the simple answer is anything and everything that enables people to come together. So if somebody said, can you do underwater banjo playing? Because my Uncle Freddie really loves that and he won't leave the house otherwise. Then we would try and work out a way of doing that. So we do a whole host of different things. So on the screen there, we've got a bit of Pilates. We've got some kettlebell exercises for older people, which is a really great thing to see, because sometimes seat-based exercises for older people, as you see on the picture on the right-hand side, tend to be a little bit undynamic perhaps, but once you engage them with something like kettlebells, then it not only looks funky, but it gives them something different to think about, that they're doing some kind of normal exercise, in inverted commas. And we've got a bit of community cooking there as well. So we provide support. So support is one of the things we do. We do that in a number of different ways. So we're a signposting organisation. So we can signpost people to financial help, to help about their bills, their gas and electric, or about benefits. We run what's called a Hope Project, which is an NHS contract we have, and you can learn hope. you can have a strategy to be hopeful. And that might be around chronic pain, that might be around healthy eating or diabetes or a particular illness you have, or it might be just about learning hope in general. And that program's been proven to give people that enthusiasm and those connections to move forward with their life and make positive choices. We run something called C Support, which is our enabling service. So this is for people that need some support in their home. It's not personal care in any way, but it's designed with a befriending background to it. So that person might need some cooking, but they don't come in and just do some cooking. It's about befriending and talking and engaging and possibly referring them into our services or other services. We run various different groups. So we've got a chronic pain group. At the moment, the waiting list in Devon is about a year and a half to see a chronic pain specialist and go on a chronic pain course in Exeter. We just happen to have a retired pain consultant who's one of our volunteers, and he runs that particular course with a GP, and that is oversubscribed beyond belief. And we also have a chronic pain support group that runs alongside that. So we have carer support groups, we've got dementia carer support group, Parkinson's carer support group, as well as groups that support that person with Parkinson's as well. Got bereavement group, weight management classes, something we call Brain Boost, which is kind of low-key cognitive stimulation therapy. So that's about improving people's brains and memory. And we've got an arthritis support group as well. And all those groups have kind of formed organically from other things we've been doing. So we have a memory cafe for people with dementia, but off of that, as we have the dementia carers group, because those carers want to get together and feel and exchange ideas. We have our lottery project, which is called C Connections, and that's about connecting people over the web area and setting up various projects, because we don't just operate from our base in Budleight, but we operate in Exmouth and Woodbury as well, and have pop-up spaces and takeover days at various libraries, various social clubs, anywhere where we can engage the audience more. We've got community transport, so we run one of the biggest community transport projects in Devon. And that brings people into Seachange. It also takes people to hospital appointments. Despite we have fact we have hospital transport service, it doesn't cater for everybody's needs, and not everybody can afford a taxi, and not everybody can utilize a taxi. So we do about 15,000 journeys a year to and from hospital and to various other locations. We've got our own cafe on site as well. We've also got a nursery on site for people, or kids, I should say, from 3 months upwards. And that enables us to have that whole demographic. Because of our community demographics, we're mainly 55 plus. But the nursery gives us that ability to do that intergenerational work, where the nursery group can go and do some singing, or the adults can go and do some reading to those children. And it works really, really well, and it's lovely to see. The impact of our support practically, we've got our virtual ward project. So our volunteers were delivering and explaining to people how to use blood pressure monitors and oxygen monitors and things like that. So they could be discharged early from the wards. The wards could still see the figures on their oxygen meter when it was being used properly and when it's being uploaded. So they were kind of in the ward still being monitored, but monitored by the individual with the help of one of our volunteers. During COVID, like many local organisations, we came together with other groups and we did a phenomenal amount of food delivery, lots of iPads that we set up and delivered to the local community. And quite a lot of shopping for people and frozen meals that we cooked. I think we did about 8,000 frozen meals, something crazy. So that was really good. I wouldn't move anywhere. We've got a lady that lives across the road with her husband. She used to come to us for our social groups. Her dementia has now moved on to a state where she needs to be looked after. But in their home, he won't put her into a care home because he knows that Seachange is literally just across the road, and it's a not a very busy road. And when she goes missing, inverted commas, she knows he knows where she'll be. She's over the road with us, having a cup of tea, not paying for it, walking out. Not a problem because he comes in the following afternoon and says, "Do I owe any money for my wife? Has she taken any clothes off your donation rail? Has she taken any cake?" And he'll come and pay the bill. And it works really well. And they wouldn't move anywhere else because of it, because we're kind of providing that little bit of support and care to them and they can stay in their home. We have social and well-being opportunities. So there we've got a bit of table tennis at the top, and we've got people there that wouldn't ordinarily come together who are talking, chatting over table tennis, who wouldn't speak to each other in the queue at the co-op, perhaps, but they're making those social connections, which are really important for building happiness and expanding your network. So we've got things like the activity club at the bottom there. So that's a group of older adults. In the old days, you would have called that daycare. We're not allowed to call it daycare anymore because it won't get funding from county council. So we come up with silly names like the activity club, but in actual fact, it sums it up quite well in that they don't come in and have a cup of tea and a biscuit and fall asleep and then go home 4 hours later because obviously they can do that at home for free. So that's about them doing some really engaging activities. One thing we've just got some funding for is an interactive projector. So that can project onto the floor, onto a table, and that enables them to play table football, to play snooker, to play games by moving, for example, their walking stick around or moving their foot around, which enables them again to be moving and doing stuff. We do some cognitive stimulation therapy. We've got a film club, Scrabble groups, self-care groups, got sewing groups. Blokes on Buses was quite an interesting one where we got some funding to basically get blokes out on a bus, go to a pub, have a laugh, go to a museum, wherever it might be they wanted to go because they wouldn't have been going otherwise. They couldn't afford to go and they would have just been stuck in their home. And we had some amazing feedback from that. Gardening for health and nature walks. We've got allotment in our gardens, so we have volunteers come in and help in our allotment and gardens, and something called gardening for health. So the GP will essentially prescribe that social prescribing to come to Seachange to do some gardening. Very low key, very simple, but it works. Calm in a stormy sea. So this was a police officer actually who's in his 50s at the moment who um, badly assaulted during a burglary and has a head injury, quite a significant one. And he comes into us and he calls us his calm in a stormy sea. And then we got another chap, William T. His wife used to come into us a lot and she died suddenly. And William is now taking on the running of our bereavement group. And that's really giving him some new focus to move on and to help other people through bereavement. This is a bit of a ridiculous slide. Probably one you should never bother using on a PowerPoint, but it just gives you an idea of the different stuff we do on different days. So, it's cycling on a Monday and nature walks. So we're not talking about just doing the odd thing here and there. There's stuff going on every day, pretty much every hour of the day, where you could come in and do something somewhere, be it actually in our venue or in some of our other venues. Happy to share this at some point if you want to take it away rather than trying to flip through the slide and see everything in a few seconds. One thing we focus on is fitness. So this is what we would call general fitness. So these are circuit classes, Pilates. We've got a gym that's really well equipped with treadmills and cross trainers and steppers and weights and things. That's just a very small proportion of it you can see there. But that gym is what we would call a non-threatening gym. So there's no pictures on the walls of abs and biceps to intimidate you. There's no mirrors. It's not loud music. It's just people in there doing their little bit. We have personal trainers and running clubs, HIIT classes, force prevention. So these are designed to try and catch the people maybe from their 50s to 60s, just entering retirement, perhaps if they're lucky enough, to keep their health and their fitness just above the right level. Got a little story there about the impact from the youth gym. Um, one of our things over the last couple of years has been to take on apprentices, and we found them to be really enthusiastic and surprisingly get on very well with older people, considering they're 17 and a lot of our clients are 50, 60, 70, 99. That relationship really works very well. And this was a mum whose son was quite introverted, having quite a lot of issues in mainstream school. And Finley worked really well with him, building his confidence, being an emotional support crutch, and just helping him come out of himself. So, and we also have our health and well-being classes. So these are low impact, seated, or optional seated. They don't have to be seated. So some people can stand beside the chair if they want to enable people to build up their strength, build up their balance, build up their bone density, obviously with the idea that they, fall over less. And these are things such as, better balance classes, postural stability classes, seated Pilates, movement for life. One thing we just started is a get up and get down class, which has proved very popular. And it literally is what it says it is. We enable you to get the strength to get up and get down off the floor when you fall. So it's not just about strength, it's also about technique and how you do it. And we've had some lovely results from that. And one of our clients, Katie, who has mobility issues, who is in her 40s, the other day, she didn't call the police, didn't call the fire brigade. She managed to get herself up, and that is just from doing a little class with us. And, if the fire brigade don't have to come out to pick her up, or the ambulance don't have to come out and pick her up, then that's £500 saved right away, let alone if they take her into hospital. So, um, and this is our fitness timetable. Again, it's a bit of a silly slide, really, in that I don't expect you to read it all, but it just gives you an idea of the amount of stuff that is going on and the amount of opportunities that people have. It's Thursday and Friday. Friday is a silly day. So I mentioned at the beginning about we focus on loneliness and social isolation. One of the reasons why I said is because of the cost of loneliness. The average cost at the moment is about £9,000 a year to local health services because, as I said, you smoke more, perhaps you drink more, bad lifestyle choices. And we did an exercise just after COVID, and we think we save around £240,000 a year to local health services just through the work we do with loneliness. That's just by bringing people together, which is not rocket science. It's just about bringing them together, making them understand the value of friendships and connections. Physical activity, so those low impact exercise classes, those seated exercise classes, the average cost for a fall at the moment is £2,600. Obviously, that's an average, so you could fall over, and as I said earlier, it might cost £500 for the ambulance crew to come out and pick you up if they'll do that. Or you might have that and you get admitted and you stay there for 3 weeks, 4 weeks because you can't go back home because you're in fear of falling again, and there's nobody to look after you. Then obviously that £2,600 probably turns into £26,000 quite quickly. And surveying our users, we think we save £280,000 to the NHS just from what we do in our little bit of East Devon. And the financial impact of what we do is a little bit of just what I said, but also around carers hours. So if we say that somebody with dementia comes into our memory cafe, that carer then has the opportunity for those few hours. So that's between 10 and 4 o'clock. So it's more than a few hours of a normal memory cafe. It's a whole day session. To go and get some rest, to go and get some sleep, go to Tesco's or whatever they need to do. And that's about 14,000 hours that we're saving there, so which adds up to £280,000. Through our salary, I think easily 500,000 we put into the local community. The hospital, when it was run and up and running, was costing around £2 million a year to run. And we do the same thing now for 600,000. So it costs us 600,000 to run the hospital with our staff, and we are helping around 8,000 or having 8,000 people a month come into our venue. So some of those people are the same people coming in and out, but it's still 8,000 people a month, which is whatever it is, 90,000 a year, um, which is a lot of visits coming into us. So you might say, is it, that's 90,000 people coming in a year being helped, or you could have a stroke hospital with 16 beds helping 16 people every week, let's say, because that's what it was before. So from a community perspective, if it was a binary choice, then I would go down the health and wellbeing hub route rather than the 16-bed hospital. I think there's obviously a place for both, and we need both. But from my perspective, when you look at the cost of what it costs us to do what we do and the financial impact we make, it's much greater. We've got about 115 volunteers. About 1,000 people are registered on our transport. That's our minibus there. It's very subtle with our branding. Saying to Eleanor earlier on, one of the reasons for that is because we want our branding to be a bit bold so people see us and understand us, that what we're trying to do is a little bit bold. Why should it be boring and battleship grey just because most of our clients are slightly older? It shouldn't be kind of hidden away. It should be something people are proud of and see, and that branding has worked really well to get us established in the local community. We're a catalyst for long-term relationships. I don't think we've had a wedding yet officially, but there's certainly been quite a few long-term relationships. Model behaviors, when people come into us, they might think personally they're in a bad way, but in actual fact, they meet other people and they realize, well, in actual fact, they're not in such a bad place as they thought they were, and it's a lot easier to get out. And we also advocate as the VCSE network. So we work around and lead 150 other voluntary organisations that we enable to come together to share experiences and best practice. One of our kind of last slides really is why isn't everyone doing it? And I don't know really, I suppose, but I can have a guess. And it does come down to money. Despite the fact that, we save the NHS money and social care money, and the CEO of the trust in Exeter knows that and agrees with that. The chief exec of the ICB knows that and agrees with that. But they can't put the cart before the horse and spend the money on the prevention. They see it as prevention, and they don't have enough to spend on the acute sector, they would say, and have some left over to spend on that prevention agenda, which is really sad, really, because that's what Chris Whitty was exactly advocating for 18 months ago, was, about that prevention agenda. But he's not in charge of the budgets, unfortunately. So it's taken, money from the League of Friends in order, they put their money where their mouth is. They spent probably nearly £1 million now funding us. We have to raise around 180,000 every year. So as I said earlier, we turn over 600,000. 400,000 of that we get in income of various different forms. So that might be people coming to pay for the gym. That might be people using our transport service. We sublet some space back to the NHS, ironically, when they said that the hospital was surplus to requirements, and yet here we are, and we rent space back to the NHS. Somewhat ironic. And all of that brings us to about 400,000. So that's 180,000 we have to find every year, and that gap has got bigger every year. And we need to raise that money by speaking to grant-making trusts and the national lottery, local organisations, local businesses, promoting ourselves as a charity amongst the local community so they know they can give to us. one of the issues we have is around people understanding that we're not the NHS and we're not free. It doesn't run on air. The NHS don't give us any funding. So it has to be paid somehow, and getting that over to people sometimes has been difficult. So we have a fundraiser, and unfortunately we have to spend time and effort that distracts us from doing our core work by having to fundraise, which is really frustrating. When common sense says you need to prime the pumps, otherwise it's only going to get worse and worse for the acute sector. One of the other issues is NHS Property Services. Certainly our building is owned by NHS Property Services. We gave it to them. We've asked it for them back, and they said, yes, we can have it back, and it's going to cost you this amount. Thank you very much. Which was a bit cheeky, really, because we gave it to them for free, and they've had it for free. They utilised the benefit of it, i.e. it's on their books, and yet we have to buy it back. So another irony. And NHS Property Services tend to be a computer says no organisation. So unless you find the right person who's willing to do something, even convincing them to do something off the norm is really difficult. So as for one example, if you rent a hospital from NHS, then you have to use their structure for facilities maintenance. You're not allowed to use your own structure. We pushed and pushed, and eventually we're now in a situation where we do our own facilities management, which is the only NHS building in the country that does that. But trying to get the accounts department of NHS Property Services to understand that is tricky, because they still send us bills every month to service the lift, even though they don't service the lift. So their systems aren't set up to cope with something that's a little bit different. The other issue, I think, is around beds. People focus on beds a lot, as I said earlier on, and there is a place for both. My dream would be, we've got effectively 1,400 square meters of space, but a lot of that is unusable. So we could effectively have another building within our building which could use that utilized space. If we were to knock our building down, build a modern building that's efficient with low costs, we could have the beds at one end and we could have the Seachange bit at the other end doing the prevention bit. That would be the goal. And I think the other issue is around leagues of friends. Sometimes have got to get a bit more with the program, perhaps, and they're, through no fault of their own, stuck in how they did things 20, 30, 40 years ago, because some of those league of friends were probably there 20, 30 or 40 years ago. So we need to inspire those leagues of friends to come up with new ways of doing things. But ultimately, I think it would take the NHS itself to have a wholesale look, and those local trusts to do something. And until those local trusts, for example, we've been talking to Somerset for quite a long time about what we've been doing, and they've been trying to work a way of fitting us, not us doing it, but fitting us, our model, if you like, into their community hospitals. But they've been struggling to do that with everything else that's going on in the NHS, and certainly the last 6 months hasn't helped that at all. So there's a lot of reasons why it's not happening, but primarily I think it's financial. It's not being able to prime those pumps to really put money into prevention. And this is just a photo I like, really. We talk about relationships. This is our dementia group. And these two people didn't know each other a couple of years ago. They're both married to other people. But when they come to us 3 days a week, they think they're married to each other. So they walk around holding hands all the time. They sit and eat dinner together. It's really lovely to see. And husband and wife are more than happy with that. So I feel like I've been rabbiting on for ages, and hopefully I haven't bored you all too much.
Oh, thank you so much, Mark. That was amazing. I mean, you've covered so much ground. And I think one of the key messages from this is that a community hospital without beds isn't necessarily a lesser thing or a negative thing. So much can be offered. I can't believe, the range of services that you offer to the community. It's fantastic, and clearly with your leadership, this is what's happening.